Assalamu alaikum. My name is Dr. Saima and today I'll discuss a very high yield topic of FCPS part 1, that is diabetes mellitus therapy. So we know in type 2 diabetes there is insulin resistance. So we will divide oral hypoglycemic into 4 major categories, that is as insulin resistance is there in type 2 diabetes mellitus. So first of all we will increase insulin sensitivity. The other one is increase insulin secretion. Third one is glucose induced insulin secretion, and the fourth one is decrease glucose absorption. So how to increase insulin sensitivity? We have two major categories. One is biguanide, in which there is metformin. It is the first line drug of type 2 diabetes mellitus, and the other one is pioglitazone. So first we will discuss metformin. Metformin inhibit mitochondrial glycerol 3-phosphate dehydrogenase. It inhibits hepatic gluconeogenesis and it inhibits the action of glucagon. So in short, it acts on liver to inhibit hepatic gluconeogenesis, and it acts on adipose tissue and skeletal muscle to increase insulin sensitivity, peripheral glucose uptake, and increase glycolysis. The major adverse effect that normally comes in exam is lactic acidosis, vitamin B12 deficiency, and GI upset, cirrhosis, sepsis, hypoperfusion, and in patient with renal insufficiency. Second one is pioglitazone. The main MCQ was the action of pioglitazone. So it activates PPAR gamma, a nuclear receptor which increase insulin sensitivity and levels of adiponectin. So further it regulates glucose metabolism and fatty acid storage. But pioglitazone has many side effects, like it has increased risk of fractures, weight gain, increased risk of fractures, edema, heart failure, and it has delayed onset of action, so it is avoided mainly. The second one is increased insulin sensitivity and very important sulfonylurea and meglitinides. So we have first and second generation. Sulfonylurea first generation includes chlorpromamide, tolbutamide, but it has disulfiram-like reaction with first generation sulfonylurea, so they are rarely used now. Sulfonylurea second generation includes glipizide and glyburide. It closes potassium channel in pancreatic beta cell membrane. Cell depolarizes insulin release via calcium influx. The major side effect of sulfonylurea is hypoglycemia, increased risk in renal insufficiency and weight gain. Meglitinide has the same mechanism of action. It includes rapaglinide and netiglutamide. So first we have discussed the insulin sensitivity, then we have discussed insulin secretion. Now we will discuss glucose induced insulin secretion, how it is increased by GLP-1 analogs, glucagon like peptide 1 analogs. It includes exenatide, liraglutide, and semaglutide. It is widely used in patients with diabetes and obesity, as it causes weight loss and increased satiety. These are its side effects, but they are often required, desired. So the mechanism of action is as they are glucagon-like peptides, so it decreases glucagon release, and it decreases gastric emptying and increase glucose-dependent insulin release. The main side effect, which no other anti-diabetic has, its side effect is pancreatitis. DPP4 enzyme inhibitor. Actually, DPP4 enzyme deactivates GLP-1 analog, GLP-1. So when DPP4 is inhibited, GLP-1 increases, and it has the same action like GLP-1 analogs, It decreases glucagon release. Glucagon is an enzyme secreted by pancreatic alpha cells. So it acts on pancreas and it inhibit and decrease glucagon release. It acts on stomach and decrease gastric emptying, and it acts on beta cells of pancreas and increase glucose dependent insulin release. The fourth category is decreased glucose absorption. Sodium glucose co-transporter 2 inhibitors, as we have discussed in insulin actions, that SGLT1 and SGLT2 transporters are mainly present in intestine and kidneys for glucose absorption. So when SGLT2 inhibitors are used, glucose is not absorbed in proximal convoluted tubule of kidney, and glucose is released in excreted in urine, so it's glucose urea. As the SGLT2 inhibitors drugs are empagliflozin, canagliflozin, dapagliflozin, so this flows glucose in urine. Due to glucose urea, there is chances of UTI and vulvovaginal candidiasis. The second action it causes is natriuresis and osmotic diuresis, due to which there is dehydration, and it decreases blood glucose, blood pressure, serum sodium, and decrease ECF volume. So as I have told, the mechanism of action is it blocks the absorption of glucose in proximal convoluted tubule, glucose urea. It should be used with caution in renal insufficiency, decreased efficacy with decreased GFR. The next category is alpha glucosidase inhibitor, which decrease glucose absorption, and it is widely used postprandially because it decreases postprandial hyperglycemia. But what is its mechanism? It inhibits intestinal brush border alpha glucosidases. What does alpha glucosidases do? They are important in carbohydrate hydrolysis and glucose absorption, but it is inhibited, so carbohydrate hydrolysis will be delayed and delayed glucose absorption. Alpha glucosidase inhibitors are used to decrease postprandial hyperglycemia. It has not that much side effects, GI upset or bloating, but it is contraindicated in renal insufficiency. So the others are amylin analog, pramlintide. It again act on pancreas alpha cell and decrease glucagon release, and it acts on stomach to decrease gastric emptying. So the side effects are hypoglycemia, nausea, and increased satiety, which is often desired. So let's discuss their side of action. So as I have told, increased insulin sensitivity, where does it metformin and pioglitazone acts? They basically act on adipose tissue and skeletal muscle to increase insulin sensitivity, and on liver it decreases glucose production, inhibition of hepatic gluconeogenesis. The other one is sodium glucose co-transporter 2, SGLT2 inhibitor. SGLT2 inhibitors include canagliflozin, empagliflozin, and dapagliflozin. It acts on kidney and decrease glucose absorption. Alpha glucosidase inhibitors, as we have already discussed, they are present in intestine, and they act on alpha glucosidase inhibitors act on intestine and they decrease glucose absorption there. The other one is sulfonylurea. Okay, sulfonylureas, they act on pancreas beta cell and increase insulin secretion. GLP-1 analog, DPP-4 inhibitors, they act on pancreas alpha cell to decrease glucagon release. They act on pancreas beta cell to increase insulin secretion, and they act on stomach to decrease gastric emptying. So Leftover are meglitinide, as it increase insulin secretion, so it definitely act on pancreas beta cells, and amylin analog which decrease glucagon release, so it acts on alpha cells of pancreas, and it acts on stomach to decrease gastric emptying. This was all about diabetes mellitus therapy. So we must know that for type 2 diabetes mellitus, metformin is the first line. All diabetic patients should receive education on diet, exercise, blood glucose monitoring, and complication management. Thank you so much.